Okay, standard precautions are in place, and anytime you're responding to a call, one of the first things you want to do is to make sure that your scene is safe.
The scene is safe.
All right, I'm also going to want to know in advance, if at all possible, the mechanism of injury or the nature of the illness of that patient.
A 54-year-old white male whose family states patient won't wake up after falling at home.
Okay, patient's fallen and he won't wake up. I want to know how many total patients I have.
You have one patient.
And as I enter into the scene, I'm going to look around to make sure if I need or do not need any additional help.
None at this time.
And also begin looking at the patient and the surroundings to figure out whether or not I might need to consider spinal immobilization.
Since this patient has fallen, C-spine should be considered.
Okay, so as a result of that, I'm going to dedicate my partner to holding the spine and immobilize. So I'm going to approach the patient. Sir, can you hear me? Are you awake? There's no response. I'm going to do a sternal rub. Patient does not respond to pain. So the next thing we're going to do is open the airway, probably using a modified jaw thrust, and I'm going to have my assistant maintain the airway in an open status. All right, the patient is moving air, but he is unresponsive, so I'm going to measure and insert an oral airway. I'm going to apply high flow oxygen to this patient. Patient has a slow, bounding central pulse, and the patient has a slow, bounding peripheral pulse. So as a result of this patient being unresponsive, I'm going to deem this to be a priority patient, and we're going to move into our rapid secondary assessment at this time. I'm going to check the head. All right, and this patient has a depressed skull fracture here on the left side. Okay. Facial bones seem to be intact. I'm going to check the neck. Trachea's in the midline. No jugular vein distension. And I don't see any subcutaneous emphysema. Shoulders appear to be okay. Chest seems to be okay. I'm going to palpate the abdomen. The abdomen is soft. Pelvis seems to be stable. No trauma noted to the leg. I have a peripheral pulse. No response to pain. Left leg seems to be intact. Peripheral pulse. No response to pain. Right arm without injury. Peripheral pulse. No response to pain. And the left arm, no injury, peripheral pulse, and no response to pain. Okay, this patient is unresponsive as a result of a fall. And at some point I'm going to have to check his back. So we're going to go ahead and measure and apply a cervical collar to this patient. Once that's in place, we're going to log roll the patient onto his side. Back is clear, and we're now going to log roll the patient back onto a long spine board. Okay, I'm now going to go ahead and check the patient's vital signs. And the patient has a fixed and dilated pupil on the right side. So I'm suspecting now that this patient may have some type of closed head injury. And the core temperature is warm and dry. Okay, so I have interventions in place which include an oral airway. I have the patient on high flow oxygen. I'm having my partner monitor the breathing in the airway. We have the patient on a long spine board and the patient's now strapped down. So those are our interventions. We're going to go ahead and transport the patient. During transport, we're going to reassess, which will repeat our primary assessment. We'll repeat our vital signs. Excuse me, we'll repeat the rapid secondary assessment. We'll repeat recheck our interventions and adjust them as may be necessary.